So I'd like to welcome everybody to our RAPM webinar for Train Tool Overview. The people who are here from the Train Leadership Team, Dr. Cullen, who actually created the Train Tool initially in the neonatal population, Dr. Kay Daniels, who has expanded the Train Tool to include obstetric patients, and Christine Taylor, who is really integral in the implementation of Train throughout the hospital, but also with integration of the tool into our electronic health record, and then myself, who helped with all of these processes, specifically to general pediatrics.
Hello, everybody. Okay, there we go. Good. So I just wanted to make sure everybody is clear that we're talking about a disaster which the Joint Commission describes as the kind of emergency that, due to its complexity, scope, and duration, requires outside assistance. And that's really important to understand that concept. We're not discussing what to do in a minor problem. We're talking about what to do in a true disaster. Next slide. All right. So this was developed by the team that Anna already alluded to at Stanford. It started in the NICU and spread throughout the rest of the operation. We've managed to program it into both Cerner and Epic. It can be taught just in time to be used for paper, but that's not the best way to do it. It is currently used in multiple organizations and growing every day. And we are consulting with multiple organizations on that implementation, and it's been used in disaster drills by both Stanford and multiple other places multiple times over the last roughly 10 years. Next slide, please. All right, so this began slightly over 10 years ago and was actually prompted by, I believe, swine flu or bird flu. We started looking at what impact that might have on the NICU. And though we realized that the flu wasn't going to affect neonates, we realized there were many things that could affect the NICU. One would be the need to transfer large numbers of neonates from one hospital being forced to evacuate to another hospital that was still functioning, but probably had a NICU that was already largely full. Go ahead. It could be because of a bunch of OB patients being diverted from a hospital that was taken out of action because of an earthquake, a fire, a flood, or staff knocked down by the flu. Next, please. All right. It could be due to an acute increase in the patient-provider ratio due to a pandemic or something like that, taking care of your own staff. If most of your staff is out sick, then you're going to have trouble. But the point of it all was that any major disaster, closing an individual children's hospital would be by definition a disaster, because multiple hospitals throughout a region would have to be mobilized to absorb a couple of hundred patients forced to be moved if we truly shut down one large children's hospital. Next slide, please. So the goals for an inpatient disaster plan, number one, it has to be simple, and it should be part of pre-planning. You can't really do just-in-time training while your building's on fire. Next. We need a triage for assessing inpatient resource needs, because moving patients is all down to resources. Next. Surge, we're going to need to work on ways to rapidly expand resource availability in the community throughout the region. That's surge. And D, and again, it has to be regionalized. We all have to be talking to each other with a common code. We all have to be working together to move patients to available resources, or potentially to move resources to where the patients are, and thus minimize the need to resort to austere care for small kids. Next, please. And it came down to the question of how do you triage this? And the arrow points out that in the midst of all of this equipment, there is an infant that would need to be triaged. And no existing triage system 10 years ago had any idea how to deal with this. Next slide, please. So amongst the identified challenges, we realized first and foremost are really limited transport resources. If you go back to Hurricane Sandy in New York and the evacuation of the NICU at NYU, you can actually see the pictures taken in broad daylight of the almost 200 ambulances lined up in the street waiting for the planned move, which happened, unfortunately, in the middle of the night. But by the afternoon before, they had the National Guard and something like 170, 180 ambulances lined up and ready to go with preordained destinations. We're not likely to have that luxury when an earthquake takes out a hospital in LA or in Seattle. Okay, there is no standardized system currently for rapidly triaging inpatients that links up with transport needs. And again, as I pointed out, the evacuation of a large freestanding children's hospital would immediately require regional cooperation, given the number and complexity of the patients. Next slide, please. Here we go. So yeah, most medical triage, if not all at the time, was designed to deal with mass casualty events, and they were for military and battlefield use. These were all pre-hospital assessments and predictors of mortality and really didn't apply during a hospital disaster. And so even though, for instance, even in the NICU, there were tools for trying to predict mortality on the day of admission, they're kind of irrelevant for a now 1-month-old 600-gram 26-weeker who's been alive for the last month. And similarly, there's nothing really out there for bigger patients who've already been admitted are on ventilators in ICUs. Next slide, please. All right, so we need to be able to quickly assess and accurately request the right resources that our patients need from an emergency operations center. We need to be able to communicate rapidly with a common code. Again, this became painfully obviously in the NICU because from a NICU talking to an EMS person at a county command center, they're not conversant with neonatology and don't want me to stand there and try to sign out one after another of 40 some odd neonates in my NICU. We need to implement a standardized and hopefully automated inpatient triage system that will work with minimal impact to workflow. During a disaster, your staff is going to be overwhelmed with tasks and can't really be running around dealing with this. This needs to be pre-planned and almost automated. Okay, we need to increase awareness of disaster preparedness throughout our institutions and throughout our regions, which is, of course, what RAPM is all about. Next slide, please. So what is the TRAIN tool? What it is it's a disaster triage tool designed for hospitalized patient movement. It is based on resource needs. Okay, so you assess the needs, the resource uses of a patient to determine the kind of transport resources needed for patient movement. And it was created with expert opinion, aligned with local EMS protocols, and beta tested in multiple drills around California and elsewhere. Next, please. This is the basic schematic of it. You can see that neo and peds are slightly different from obstetrics, but they basically do the same thing. We look at a person's resource needs in 4 domains. For instance, in neo-peds, it's life support, mobility, nutrition, and pharmacy. And based on their resource needs, they are assigned to one of 5 categories that relate to their transport needs. They can be sent out in a car, in a minimal ambulance like a Medivan, a standard basic life support ambulance, an advanced life support ambulance, or they need a specialized rig and crew. Next, please. So this is looking at the pediatric TRAIN tool now that encompasses pretty much all of pediatrics and quite frankly is applicable to adults too, but we won't go there today. You can see the 4 domains: life support, mobility, nutrition, and pharmacy, and you can see the 5 transport categories. And whichever transport category is the patient's need farthest to your right, that defines it. If they meet the need for a specialized transport resource in any domain, then they need a specialized transport resource. There's no math, there's no calculation, there's no ordering blood gases or platelet counts. It's very simple. And because it is so simple, and because it is based on resource use, the EMR can do this automatically. Your hospital EHR or EMR knows exactly what resources your patient is using. Next slide, please. So here you see a simple example. You can see this child. She's a 3-day-old. She's a 29-week preemie, pulmonary hypertension, high-frequency ventilation, INO, NPO, and so forth. And you can see, you can look at the grid above and see she checks the box for red. She's a red. This girl cannot go in an ALS rig. This girl needs to go in a rig with people who are qualified to take care of high-frequency oscillation and INO. She's specialized. Next, please. And this is what we found. This is a couple of years old, but we've done this multiple times. It doesn't change that much. This is what happens when you look at a snapshot of a major children's hospital on a given day. And I'm sure this is the same for the Children's Hospital at Oregon or Seattle or Las Vegas. You can see there's a lot of patients that end up in the red and orange category, but there's also a significant number of patients who end up in the green and blue. In other words, patients who can be moved with minimal resources. All right. But when you show this to your county EMS person, tell them that you're going to need 38 specialized and 61 critical care rigs, they kind of turn very pale and get the point quickly. Next slide, please. All right, I'm going to hand over to Kay Daniels to talk about the OB version.
Hi, everybody. So I know I'm speaking mostly to pediatricians at this point, but as I always say, OB is where babies come from. So it's important for everybody to understand obstetrical needs during a disaster. So, and also you can communicate with your OB people to get them on board. So when Ron came up with this train idea, we realized right away on obstetrics we needed the same kind of thing. And the question is why? Well, in the United States, greater than 97% of births all occur in a hospital. And this hospital, this picture you see of the Kaiser, is after the Northridge earthquake. So obviously no births are going to go on there, but next slide. But in addition to births, is a pregnant woman is particularly vulnerable to physiologic changes. And even though they're not at, say, more risk of injury, when they are, their care becomes more complicated. So making sure that we can get pregnant women who have been injured to a maternity hospital who can care for both mom and baby is crucial. Next slide. So here's a couple things I want people to understand about OB, because we're not just adults. And the OB population is very unique, and it's really important that the hospital understands our issues. We are not one size fits all. Most of the time in OEM or any kind of disaster planning, everybody on the floor pretty much looks the same. You know, if you're on a med-surg floor, even if you're in ICU, they generally all have the same acuity level. But that's not true for OB, because our footprint has a large variety of patients in need. And as you can see the pictures below, we're dealing with a laboring woman in one room. Go ahead. And then right across the hall, there might be someone in the middle of a cesarean section, and down the hall, someone in the ICU. So we are the one ward in the hospital where you have to actually consider multiple plans, anywhere from a healthy woman who can walk herself and her baby out the door to a patient that is in the middle of surgery. And having some kind of plan for these extremes is very challenging. Next slide. And of course, we have two patients. So anytime we're determining where to send a baby and a mom, or where to send a antepartum patient, we're considering both mom and baby together. And this is something that's very unique for obstetrics, and something that is not fully understood in hospital emergency management. You can't just send a pregnant woman to any hospital. It has to be one that can accommodate either her or her baby or both. So next slide. The next issue is about keeping mom and baby together. And this is neither trivial nor is it easy. It is quite a challenge to be able to coordinate mom and baby together. And as seen in Katrina, in some cases, it was 10 days before mom and baby were reunited. Now, I'm sure this was due to a variety of issues, but likely part was due to a lack of a plan in place to assure mom and baby are sent together. Emergency operations needs to be cognizant of this very unique issue of obstetrics, because separating mom and baby for that long not just emotional, but breastfeeding and all the other issues that go involved with taking care of a newborn, you have lost that crucial time. Next slide. So we're going to talk about train in terms of evacuation, although as Ron tells you, it can also be used for surge and can be used for other events. Next slide. But in terms of evacuation, OB train based on Ron's resource for allocation for inpatient goes as follows. Next slide. For us, the parameters are these 4 parameters. And this is just for labor. We have a different train for postpartum. But is the woman in labor? Can she walk? Has she had an epidural? And are there any maternal or fetal risk factors we have to consider? Look at the simplicity of this. Any obstetrician would be able to tell you within 10 seconds the situation for their patient with these parameters. Any bedside nurse who is taking care of that patient can tell you all these answers. And that's what's important. It has to be simple and it has to be up to date. As you all can understand, some of these parameters will change very quickly, especially labor status. So keeping it simple is paramount. Next slide. Here's what it looks like physically. On the left, you see the labor status, and on the top, you see, just like what Ron was talking about, the different colored codes for either you can discharge a patient home, or they're going to have to go to another hospital, or they need specialized care. And as you can see on the very end is a very big square for us, probably more than any place else in the hospital, is shelter in place. There will be situations on labor and delivery that we cannot move a woman that is about to deliver. So we'll have to deliver her first and then send her out. So being aware and ready and having plans in place for this kind of situation is also paramount. Next slide. Probably the best way to explain this is to go through 2 very simple examples. So we've got a 26-year-old at 40 weeks, which is term. She's 4 centimeters, which means she's in early labor. She can walk, and she has no epidural. Okay? Baby is category 1, which basically means baby's fine, and mom has no problems. And just like in the NICU and PD train, you take the most acute situation, which is she's in early labor. So you're not going to send her home, because even though she meets 3 criteria for the blue, she meets 1 that makes her needing to come to the hospital. So you're going to put her in a BLS rig, and you're going to send her off to another hospital for her delivery. Next slide. So here's a little bit more example, a harder example. Here's a 32-year-old at 31 weeks. So she's premature, she has severe preeclampsia, and because of that, she's undergoing induction for the safety of her and her baby. So she's undergoing induction, she's only 2 centimeters, so that's early. She's not walking, and she has an epidural in place. Her baby looks okay. However, she is receiving IV labetalol intermittently for her blood pressure control, and she's receiving a continuous dosing of magnesium sulfate. This magnesium sulfate is very high-risk medication. It has to be carefully watched because it has a respiratory depression aspect to it. So in her case, even though the baby looks okay, she needs a specialized rig taking her to a high-risk hospital. And that specialized rig for us means that there's a labor and delivery nurse or an MD who can push her labetalol and watch the magnesium sulfate and make sure her respiratory status is stable. So you can see how quickly this can all be figured out. In fact, I think the next slide. Oh, that shows you a specialized. Let's go to the next slide. This is an example of how quick this can happen. One evening, I sat down and just went through all the patients on our labor and delivery and postpartum unit. So we have 2 floors of postpartum and a 10-bed labor and delivery. And I was managed using the medical records. So I wasn't asking the nurses, just using the medical records. I was able to go through all 35 patients, and this is how it broke out. Most patients can be discharged, so we need a plan for that. 12 had to go to another hospital for delivery or further monitoring, and 5 had to go to a more advanced hospital, 2 for specialized transport, and 1, delivery was imminent, so she was shelter in place. So having done this just with the EMR, I was able to figure out that every single patient on our unit were a tertiary unit, a tertiary hospital, and I was able to figure out everybody's status in less than 30 minutes. So this is easy and it's fast, and that's what you're going to need for a triage. Next slide. There's another aspect of OB disaster planning and triage and evacuation that you should be aware of, and that is that not every patient can go to just any OB hospital. There needs to be, much like the NICU has different levels of care, maternity hospitals of care also exist based on who's in the hospital, 24 hours, do they have MFM available, do they have specialized care available for the fetus or mom. So based on the capability of the hospital, the type of providers, you're going to send your patient to the right hospital, only knowing ahead of time what each one of your local hospitals are capable of. So next slide. So during an acute event, you're not going to have the time to actually understand which hospital can take which type of patients. So I encourage any labor and delivery units to develop a chart of all their local hospitals that can show both what level mom they can handle as well as what level nursery. So I'm hoping you can see on that slide that we start with LPCH, that's our hospital, and we are maternity level 4, neonatal ICU level 4, and all the reds are either 3 or 4, maternity or NICU. And having this kind of chart ahead of time when you're in the middle of evacuating your unit is going to be very valuable. So that's all for OB, and I will turn it over to Christine.
Hi everyone, nice being here today. I'm just going to talk a little bit about the integration of TRAIN into the electronic health record. We've done this in 2 incidents, once in Cerner and once in Epic, and we have also helped a couple different organizations with this. So really the value of it is it's non-biased. It pulls discrete data points from nurses' charting and orders, and you're able to validate the coding to make sure that all the patients are scored correctly. So an automated process that updates with charting, which is great. Next slide. Along with that, since it's in the electronic health record, you're able to create automatic reports, which we do send daily to our Office of Emergency Management and our nurse supervisors. You're able to really run the report at any time to see who's in-house. We also have it on our downtime computer in case anything goes down, so we at least have the last scoring. And the purpose of our TRAIN report is to help with decision making. So like Kay talked about before, she had to go in and look and categorize all of them. Now all she would have to do is run the report, already has all the categories, and then can start making decisions as a provider on who goes first, what medications we can change to help move the evacuation process forward. So this is just an example of what our report looks like. This is by unit. We have each patient and what triggers their color scoring. And then we also put down their emergency contact information so we can run the report, take it in. If we need to take it with us and leaving the organization, we have that emergency information. Next slide. The other thing we have is a summary at the end of our report, so it gives us an overall sense of what our organization is looking like. by category codes, and we also added on our disaster beds to see how many total empty beds we have and how many add-on disaster beds we have in case we need to understand that. We did this for our sites here at the hospital, then our off-site areas, and then in our peri-op areas, just to understand where patients were at that current time. Next slide. So as a time comparison, we did do a time study to see what this looked like. We had a mock scenario that we were doing with the state. And so the command center, with our old process, reached out to the units to find out what their resource need would be for transporting all their patients out of the hospital. And then we had one person run around the hospital and assess everyone with the paper. And then we ran the report with the computer. So as you can see, computer took 48 seconds. The person running around, who was an expert with the Train tool, was able to do 148 patients in 57 minutes. And after we completed our disaster drill, at the completion of that, 2 hours later, we still didn't have anything back from the units to know what their needs were. So really, computer is the way to go. You can have it very quickly. Next slide. And I'll turn this over to Anna.
Right. So we've talked a little bit about the use of the Train tool for evacuation, and that's probably, it was with that in mind that the original tool was created. However, we actually have seen that we're able to use the tool in other situations operationally. So not only are we talking about a vertical evacuation, the infrastructure of your hospital is somehow impacted to the point where you can't care for patients safely any longer within the hospital, to like planned evacuations such as a facility move, which people have actually done, as well as kind of lateral movement within a hospital. So decompression of our ICUs or of our floor patients with rapid discharges out. We can use the tool to determine that, as well as to identify patients who could be rapidly moved from one unit to another. So we talked a little bit about lateral movement and patient flow and movement. And then the most recent use of the Train tool that we've actually used for was planning for a surge on our hospital within the pandemic. And what we've actually come to realize is that although it doesn't 100% track, the majority of the time we're actually able to assess the acuity of a patient based on the tool's categorization. And so in this sense, we're actually able to plan our staffing. So if we had a surge of critical care patients, which patients would we be able to staff 6-to-1 or 4-to-1 or 2-to-1 with our nurses, or which of our patients could be staffed by non-critical care physicians such as anesthesiologists or hospitalists. I think where this tool actually really becomes important is in regionalization and disaster planning from that standpoint. So the nice thing about the tool itself is that it actually has a common code, and so that we all want to be having the same tool with the same definitions, so that if our hospital is completely burning down and we're evacuating and we know that there's 5 or 6 different hospitals that we have to evacuate to, we can actually just quickly tell the receiving hospitals what types of patients are coming without giving a super detailed handoff, because there may just not be time to do that. The advantages that we have of the Train tool, which Dr. Cohen had previously discussed, is to really implement a standardized and automated inpatient triage system. And we really wanted to minimize the impact to clinical workflow, whether it's a nursing workflow, whether it's a physician workflow, whether it's an administrator-like workflow. The other point of this is to really be fast and accurate to get the right resources to our patients or get our patients to the right resources, and be able to do this in a very expedited way with our emergency operations centers. Obviously, the most important thing is really streamlining our communication with a common code. So there aren't any triage systems that are out there that can actually serve this function the way that the Train tool does. It's been included in our FEMA PEAKS training as a best practice, and it has been adopted or is in the process of being adopted by all of the NICUs in California, San Diego County, Central Florida, New York City, Sutter, and others. It's also been endorsed by the Western Regional Alliance for Pediatric Emergency Management, the RAPM group, which is who we're giving this talk to for now. And join us in the TRAIN consortium. Again, we do want to have coordinated care across the region with a common code. By joining the consortium, you'd actually get assistance with implementation, validation, and quality assurance, as well as continuing education. And you can contact us at train@stanfordchildrens.org.